Now, this thought came from really in the context of lots of jurisdiction being like, you know what we're going to do to this very vulnerable population, which is transgender youth. I think what we should do is prevent them from accessing transition-related medical care that they so sorely need. So you have places like Arkansas, Texas, I think that Oregon, no, Ohio, I don't know, they kind of all sound the same to me, but lots of US states are now trying to just straight up ban any sort of gender affirming medical care for anybody under the age of majority. In some places, some people are even talking about potentially trying to go all the way up to 25. And part of the argument being that this would be like experimental or insufficiently proven. And a lot of that argument is focused on the claim that somehow the mental health benefits would be insufficiently proven. So it's really starting from this presumption that you need to meet some like threshold level of evidence of mental health benefits in order to justify access to transition. So what I'm doing today is presenting an argument against that, which is currently under peer review, and you're in fact the first audience who gets to hear this argument. So except for a few hand-selected people who've given comments on the paper, you'll be the first to hear this argument. Now, my argument is fairly simple. That threshold, that need to prove a certain degree of mental health benefit is wrong. And in fact, when we talk about things like trans care, because it's a very unique form of care that has so much to do with personal identity, the threshold is different. Instead, anyone who wants to ban it doesn't just have to show that we haven't proven that it's beneficial, but they have to show that it's overwhelmingly harmful, sufficiently harmful indeed that it outweighs any potential, interest in autonomy and defining one's life. Part of making that argument is by analogy, because, well, at first it might seem unusual, saying, oh, but doesn't medical care have to be, have a proven effectiveness? And I concede that that may well be the case for your average kind of medical care. I don't really want to go to a doctor for depression and receive as, first sort of like first line treatment, get something that we don't even know if it's going to work, unless, of course, it's, I'm taking part in a study that's trying to figure that out. But in general, we want to offer things that work and that we know work because, well, my only interest is getting rid of depression. The same is not quite the same when it comes to certain other forms of care, but that's a little bit, hard to make as an argument, like what's so unique about trans care. So what I do is I instead turn to reproductive health and say, well, look, in reproductive health, that's how we're framing it. We're saying autonomy first, and then we look at whether, it's so, harmful that it would justify taking away rights, and we conclude, no, it's not. And it should be allowed. And, that's a big debate that's been happening in the US, is this debate that of whether there are mental health harms of abortion and birth control, which is interesting because it's very much a different kind of burden of proof, right? Like the burden of proof has been on people who want to oppose access to abortion to show that it's so harmful. And in fact, they necessarily fail because facts are not on the side of opponents of abortion. But the importance here is, I'm drawing that parallel. I'm saying, well, look, if that's the standard that applies to something like reproductive health, and if trans care is like reproductive health in a lot of ways, much more so than it is kind of conventional medical care, which tries to cure some sort of disease or at least treat a disease, then the same standard should apply, because otherwise that would be a double standard, and double standards are discriminatory. It's also an important parallel, because under constitutional law in a lot of countries, including Canada and the United States, there is a recognized right to autonomy over reproductive decisions, over abortion, over birth control, etc. So by bringing in the analogy, the argument is, well, similar, this kind of judicial trend of recognizing a strong right to autonomy should be extended to trans care. It's also a little bit of a warning, because we've seen in places like the UK and to an extent in Canada, attempts to curtail access to gender-affirming care. And if I'm correct in my analogy, then that means that those attempts could really backfire and end up also curtailing reproductive health care, which is something we should be worried about. So my presentation, I'm going to go through just to give a kind of like a mapping of the presentation. First, I'll, talk about, are they analogous? Is gender affirming care and reproductive health analogous? Then I'll talk about what the evidence base for each is, and then I'll draw some conclusions about what that entails in terms of law and in terms of policy. So the first thing that's kind of important to note in terms of the analogy between between gender affirming care and reproductive health is that neither really has anything we could call an illness or a disease of any kind that is treated or kind of cured by the intervention. It's not a mental illness to not want to be pregnant and deliver a baby. It's also not, being able to become pregnant and wanting birth control to avoid that is also not, not a mental illness. It's just a sort of incompatibility between one's desired life and a contemplated or actual state of affair. Something very similar is the case with trans care. It has been a bit blurred by the reality of kind of diagnostic categories, because oftentimes, you have this idea in the DSM, you have gender dysphoria as a diagnosis. Now, I'll return to that being a disorder, but the important part here is you, like with reproductive health, where the desire is not to cure some sort of illness or disease, but rather to access a specific intervention. The same thing is true for trans care, right? Like, people don't really go to their doctor being like, I want to cure being trans. They go to their doctor being like, I want this intervention. And as with access to reproductive health, if you do not have that access, or if you're not, if you don't have access to those services, you will quite understandably, most of the time at least, be quite distressed and be quite unhappy and quite have a lot of negative mental health consequences. But those consequences don't necessarily indicate anything that's a mental illness. It's really the lack of access to something that you seek out as a matter of kind of defining your own personal life. It's really this kind of fundamental autonomy aspect where you're seeking the intervention itself for reasons tied to your personal identity that really ties together reproductive health and gender affirming care and really distinguishes it for what I call conventional medical care, where you have a set of symptoms you go to a doctor trying to figure out what is the condition associated with those symptoms, and then you try to cure or treat the underlying condition in order to alleviate symptoms. But you're not there being like, I want this intervention. You're there being like, I want to figure out what's going wrong with me, you know? When I went to my, was at a shrink recently, and I was like, you know, specifically stated, you know, I'm here for an assessment for this or that condition, but, you know, I'm not here to get whatever is prescribed for that conditions. I just want to figure out what the hell is happening, and then address the underlying condition so that the symptoms can be alleviated, which is very different from kind of for like trans care and an abortion, where whatever would be, and in fact, there's no underlying condition, but let's say there were an underlying condition, at the end of the day, you're still going there to get the intervention itself, not to get some sort of diagnostic process going. So this is different, and how I capture the difference is you have conventional medical care where you go to this kind of diagnostic process, and where it is perfectly normal to kind of want to expect a certain level of proven efficacy to the intervention, and definitional medical care where you are seeking the intervention itself for itself, not because it treats some underlying condition, and thus your relationship to any benefit is very different. When I go for conventional medical care, I care a lot if there's any proven evidence that it actually helps. When I go to get trans care, I don't give a flying damn, because I want the care itself. I want the intervention itself. Where that also matters, and there's something, and that's where we kind of tie back to law, is there's a recognized right to, and I'm going to use the word of the US Supreme Court here, there's a right to define one's own concept of existence, of meaning, of the universe, and of the mystery of human life. And that's the word of the Supreme Court in Planned Parenthood versus Casey, which is a case that confirmed a sort of like a post Roe v. Wade case that in very strong terms confirmed the right of autonomy tied to reproductive health, because things like marriage, things like gender, things like pregnancy and having children, all of these things are so fundamental to the kind of life that you live that having them restrained by the state would essentially curtail your very ability to be who you are, to be yourself, in the name of in the language also used by Catriona Mackenzie, who's a feminist philosopher. It's about shaping the self from a bodily and a moral perspective. And we see that quite a lot, and you know, that idea of autonomy and how gender is central has been recognized in both, you know, both in reproductive health and in gender affirming, in terms of gender affirming care, because I mean, it's really hard to imagine something that's as significant as reproductive health and trans care. You know, in reproductive health, it's whether there's a literal human being towards which you have a sort of moral causality to, you know. There is or there is not another human being in the world, with all that implies. There's partly conditioned on your ability to access care, and that can be quite a heavy burden if you don't, if you did not want to be pregnant, for instance. Similarly, gender identity has been acknowledged as incredibly important, but also our gendered perspective in the world. In fact, it's quite hard to imagine something that is as socially salient as gender. There are relatively few things that are quite at that level of saliency, because everything in society seems to be organized by gender. And we also have a whole structure of reading gender onto bodies, It has so many implications in terms of our social and interpersonal relationships and how we get to then live in the world, that it really just goes to this core aspect of self that we think in general people should be able to define. It's part of really this really core autonomy of getting to be yourself. So this is another point where there's quite a big analogy between reproductive health and trans care. Another one is, of course, the social equality implications of both forms of care, right? Like if you don't have access to abortion or to birth control, that has massive impacts on gender equality, but also racial equality, class equality, and impacts in terms such as those. We know that there's a lot of discrimination towards people who are pregnant and towards people who have children, especially at a young age. It can have a huge impact on people's ability to gain an education. And it's also a huge kind of time commitment, emotional commitment, and psychological commitment to have children. So there are huge social equality implications in this respect. But similarly, access to gender-affirming care also has its implications because, well, if you are experiencing a lot of negative mental states because you don't have access to gender-affirming care, that might negatively impact your ability to continue in school, your ability to, or your comfort being outside. And then also there's the relationship to others' perception of you, where it means that if you don't have access to gender-affirming care, you're more likely to be outed as trans, and thus are more likely to be subject to violence and things like that, which, like, of course, are things that shouldn't happen to someone that doesn't get medical intervention. You know, people's respect for gender should be a given regardless of medical transition, but it remains the case that this is something that trans people have to navigate, and trans care has an important tool in to navigate that for those that want it, in addition to all the psychological aspects that are really important. Because let's face it, if you don't have the access to desired gender-affirming care, it's going to be very difficult to fully participate in civil society because of things like self-doubt, issues regarding self-recognition, but then also negative mental health consequences. So this is kind of like my bit with the analogousness between the two forms of care, but then there are counter arguments that I have to consider. So the first counter argument is, well, yes, but what about reversibility? And to that, the kind of like answer is that, well, reversibility, everything is both reversible and irreversible to different degrees, right? Like you cannot experience something that you have not experienced after the time has passed, and you cannot unexperience something. If you go through, if you take puberty blockers, you're not going to be able to sort of return back in time and have that endogenous puberty at the same time as your peers. But similarly, if you're forced to go through endogenous puberty, you're not gonna be able to unexperience it. So this idea of reversibility is a bit tricky, but it's also predicated on a very weirdly like physical concept to claim that, for instance, hormones are reversible or irreversible, because, well, as I said, everything is a bit kind of like time irreversible, and one thing, in fact, that a lot of anti-abortion advocates seem to want to put the emphasis on is the irreversibility of regret of those that they usually call women, because anti-abortion groups aren't exactly known to be trans-inclusive. What they say is like the women who regret having abortion, oftentimes after being sort of inculcated in a view of abortion as a form of infanticide, which is very problematic, but also kind of goes to show just how the very concept of reversibility is kind of malleable. And to the people who do end up regretting, they tend to see it as irreversible, right? So to the extent that we care about the perspective of the people undergoing kind of a regret, then in both cases, it is to an extent irreversible. And so it's not really distinguishing in that respect. So the idea that trans care is reversible and the other not is really kind of a matter of perspective. Now, I obviously have my own views as to how I would consider it personally, where I generally see them as in both cases as kind of reversible, but that does imply a certain personal perspective on the matter that might not be shared. But the important kind of point here is that reversibility is really is a distinction that's really based on the personal view of specific individuals, and is not clearly something that distinguishes both forms of care. The other one that's often kind of used is saying, well, yes, but wanting an abortion is not a mental illness, whereas being trans is, or at least having gender dysphoria is. Well, the first point is, like, is it really true to say that gender dysphoria is a mental illness? I mean, I think we can all agree on the fact that being trans is not a mental illness, because, well, that's been kind of put to rest in terms of like diagnostic classifications and things like that. But the DSM has kept gender dysphoria in as a diagnosis in DSM-5. However, it's important to note how the classification is very much a sort of cultural artifact. The idea of a kind of natural category of mental illness is quite questionable, as we see with things like the bereavement exception to depression. Until the last DSM, it was impossible to get a depression diagnosis 6 months following a loss of an important person in one's life, under the assumption that it was simply normal to have to essentially be depressed for that period. The line of 6 months is extremely arbitrary and is largely based on, well, a bunch of cis white guys' own beliefs about what constituted an appropriate period of grief. And anything that extended beyond that then became depression because it was considered inappropriate grief. But then they've removed that exception, and now you can seemingly get a depression diagnosis for during a grieving period. So it just goes to show how judgments about what counts as natural are and what counts as a reasonable response is really implicated in classifications as mental illnesses. And we really see that happening with trans people and gender dysphoria diagnosis, because imagine, I'm sure you've all seen Freaky Friday, so I'm going to assume you've all seen Freaky Friday, but it's about, it's this movie where a daughter and her mother, for some reason, exchange bodies and wake up in the other's body. Well, imagine if you had a similar thing happen to you, but except you get switched around gender assigned at birth. So let's say, I don't need that analogy for the trans people in the audience, I'm going to focus on the cis people in the audience. If you're a cis man, imagine you wake up in the body of a cis woman and vice versa. Well, quite naturally, you'd be like, yo, this sucks. And after a bit, when you're past the kind of novelty aspect of it, you'd probably start being very distressed because you're sort of feeling, well, that's not me, that's not my body. There's nothing wrong with this body. It's a perfectly fine body, but it's not mine. It doesn't work with me. It doesn't work with how I self-conceptualize as a human. And you would very understandably could be distressed. Now, you might not be, maybe you love that body, and that's fine. Similarly, some trans people are extremely happy with the body they were born with. But it would be certainly quite understandable if you did feel quite distressed by that situation, and yet we'd hardly say that this is some form of mental illness in your part. There's something going on that leads to distress, but it's really more of an incompatibility between your self-understanding and your bodily situation in a way that was caused by, well, in the case of Freaky Friday, magic, and in case of trans people, sort of biocognitive happenstance. So the very idea of classifying that as a mental illness is questionable, and it's also worth noting that the gender dysphoria diagnosis in the DSM was kept primarily because there were fears that it would impact access to insurance coverage. So the idea was that if you remove it from DSM, people might lose insurance coverage, and was not really a sort of good faith consensus that it was indeed a mental illness. Then on the flip side, also worth pointing out that desire for abortion has long been pathologized and continues to be pathologized. Freud called it infanticide. Anti-abortion movements continue to call it infanticide sociopathy, but then in the past, if you look at past diagnostic categorization and like the psychoanalytic literature, you have talk of hysteria. One that I found particularly gross was a divestment from Oedipal guilt and maladjustment to adulthood, which honestly could be very much copy-pasted explanations for being trans, because again, divestment from Oedipal guilt sounds like what a psychoanalyst would say about what caused someone to be trans, and hysterical psychosis has been proposed multiple times in all the literature as an explanation for why people are trans. So while popular attitudes about what is a mental illness may have shifted in a way that creates a certain disjunction between the two, we really see that both could be pathologized and also can be understood in a non-pathological manner. Also, an interesting parallel between both is that oftentimes claims of being trans and of wanting abortion being mental illnesses are predicated on some sort of elevation of something called like the feminine mystique, or the essence of womanhood, or some sort of naturalization that associates living in a certain body and having children with proper living for people who are assigned female at birth, and then vice versa, being masculine and having what they call fathering children for people assigned male at birth. So that's kind of the narrative that gets deployed on both sides. In fact, quite a lot of similarities in the language. Now, so that's kind of the answer on whether we can distinguish them on account of one being a mental illness and the other not. The answer is no. Mental illnesses are constructed, and both can be constructed kind of either way. Personally, I obviously prefer not understanding either as a mental illness. But one thing I want to kind of like emphasize and nuance here is it's not because disorders are bad. It's not because having a mental illness is bad. It's because I don't think it's a good fit in terms of healthcare explanatory theories. People who are mentally ill and people who have, non-psychological disorders certainly deserve a hell of a lot more autonomy than they are afforded in our society. Really here, why I don't think it really makes a lot of sense to slot it as a mental illness is precisely because of this difference in terms of conventional versus definitional medical care, and my overarching idea that classifications as mental illnesses or not mental illnesses should be predicated on whether it is genuinely helpful for the group in their own views and on their own terms, whether it is helpful. So for instance, I find that the concept of depression can be helpful for me because it can be used as a differential diagnosis and can be used to kind of try to define what is a good treatment option, etc. And when I'm coming with certain symptoms, it can be helpful to have this diagnostic category. The same is not true for trans health, because with trans health, and similarly with reproductive health, I want the intervention itself. The disorder is not playing any sort of treatment guidance role and is not really doing anything over and above my existing desire to have the intervention itself, which is why I think it's unhelpful to classify them as disorders. And that ties back to the question of whether mental health benefits must be or should be proven or not, because, in the case of trans health, I don't give a damn. I want titties. Just give me titties. I don't give a damn if you think I have whatever is the mental illness associated with being trans. The same thing is not true of my depression meds. I want them to figure out what's really depression or something else before they gave me meds, because I just want to get rid of those symptoms that are negatively impacting my life. And I understand myself as someone who has a mental illness on account of depression and anxiety. So that's where a nuance is important, because the last thing we want is to justify removing autonomy to people who have mental illnesses. On the contrary, they deserve a whole lot more. And in fact, I've separately from this paper, I built an account on how we can do that and accord decision-making authority without legal capacity. But that's an entirely different paper. Now, I turn to the evidence. So I've argued quite simply that there's an analogy that reproductive health care and gender-affirming care are analogous and therefore should be treated the same in terms of the burden of evidence. The second step is to ask, well, how do they compare? Because oftentimes there's a claim that, well, there is a bit of evidence of mental health benefits to trans care, but it's really of like a poor and very poor quality. And to this I turn to, well, the Academy of Medical Royal College's report on the relationship between abortion and mental health care, which looked at all the evidence, concluded that pretty much all of it was of poor and very poor quality, and concluded from that that there was no evidence that there was a detriment to having a psychological detriment to having an abortion. The entire debate was not predicated on proving benefit, but rather on infirming the presence of overriding negative consequences on a psychological level. In fact, a lot of this sort of surface level evidence seemed to suggest psychological degradation after abortion, which is the opposite of what trans care shows. But a more careful look at the evidence showed that once you controlled properly for everything, these negative outcomes completely disappeared. So that's an important point, because the Academy of Medical Royal Colleges, and there were other reports by the American Psychiatric Association and American Psychological Association, all came to the conclusion that to the extent that there's no proven, grave negative mental health consequences to having an abortion, then it should be allowed. So similarly, the logic would be, well, trans care should also be allowed unless it were proven to have these really awful, awful negative consequences. Now I want to open a very short side note on the language of poor and very poor quality, because I don't think that's very fair. The language, so oftentimes they'll say, well, proof of benefits of trans care, and similarly for reproductive health, is poor or very poor. That language almost always comes out of using the standards of evidence-based medicine. But the problem is that evidence-based medicine has never been well adapted to the realities of psychological research. It presumes that you can effectively have randomized controlled trials that you can then do a systematic review of. You can't do that in trans care or in reproductive care in regards to mental health, because what you're going to do is you would have to randomly assign people to have an abortion or not, or to get trans care or not. Well, first of all, deeply unethical. You obviously can't do that. Second of all, you don't have, it's not masked. Your participants know which arm of the trial they are in. The people conducting the trial know. There are all of those, which completely undermines any ability to get reliable evidence. So instead, people do high quality, prospective, retrospective cohort studies and a lot of cross-sectional research. Those are not poor, very poor quality. If you actually look at an appropriate scale of evidence, like the Ottawa Newcastle guidelines, which are specifically made for observational studies for cases where you cannot do a randomized controlled trial, then those would be medium to good, and in some cases very good quality research. But by applying this very kind of unnuanced metric of evidence-based medicine, you can demean anything other than randomized controlled trials, which are fantastic for things like drug safety, and in fact have been done for drug safety of puberty blockers and hormones and all of that stuff. But once you get and look at the psychological element, it's not something you can really get. So I think it's quite unfair to label the evidence poor and very poor quality on that account. Now, getting more towards the end is well, okay, so there's no, so the requiring evidence of mental health benefits is the wrong metric, because reproductive health is absolutely essential and must be preserved, and obviously I'm talking here to people who generally agree with that. And if that's the condition here, then the same should be applied to trans care, and thus trans care should continue to be available. Now you turn to the question of, are there overriding risks? And well, the answer is, well, all of the things we give in trans care, like the hormones, like the puberty blockers and things like that, well, they're all considered safe enough when we give them to cis people for different medical conditions. In some cases, for instance, like precocious puberty, you get puberty blockers for roughly the same amount as trans youth, and it's considered perfectly safe in that case. Now, weirdly, some people are trying to claim oh, but you can't use that evidence, it's a different context. And I'm like, well, yeah, it's a different kind of social context and context of why do people take it, but from their bodily perspective, it's the same damn thing. It's still the same body taking the same dose for about the same amount of time in order to delay endogenous puberty. There's also evidence that the risks of taking hormones is about the same as taking birth control pills if taken orally, and you can reduce that risk by taking it in a non-oral format. So we're talking about risks that are like well within the range of risks that we just tolerate within medicine. So that sort of concludes my argument that to the extent that the evidence base for reproductive health and gender affirming care is similar, to the extent that they serve similar purposes and are very similar in their relationship to illness and autonomy and social equality, then we should treat them more or less the same, and thus both should continue being allowed. Now, what I don't really say here with that argument is who gets to decide when and whether an assessment is necessary. Now, my arguments, it could be seen as a natural result of my argument that we don't want to assess people on whether they are truly trans. That's something I generally believe in. However, I don't think I can go this far with the present argument in the present case, because you could make potentially some sort of harm reduction argument if, for instance, there was a decently high risk of regret and a very high accuracy of assessments, then it could be considered a reasonable requirement to have the assessment. So it requires a second argument to the effect that assessments don't work and regrets are really low rates, which I do in another paper. Somehow I'm building a sort of network of papers that all rely on one another. Another thing I don't say is who should ultimately decide, right? Because while I'm talking about gender affirming care, especially for youth, and so there's the question of, well, who gets to decide, who gets to legally consent to the care when you have, let's say, a 12-year-old who wants puberty blockers. Well, my argument doesn't deal with that. That would require a separate argument that deals with the many questions about parental ability to make choices in the best interest of the child. So I will conclude here, and I'm eager to hear